cc, sometimes 50 cc's. I'm not concerned about that, but if there's a leak, we would take care of that. Okay, you can see that the peak airway pressure here is at 11, which is very good. Okay, because if it's too high, that's pressure on the lungs and it can cause pneumothorax. And we try to avoid any injury to the lung by keeping that pressure down. So this monitors.
So few things you have to remember. Peak airway pressure, don't let it go above 30. 30 to 35. It's above 30 to 35 is a problem. Okay, let people know. So just remember number 30 to 35 peak airway pressure. We are overextending or distending the alveoli, and you can have alveolar injury, or you can have pneumothorax. So that is the one. Number two is that the mean pressure. We need good mean pressure, because mean pressure keeps the alveoli distended. Okay, so to prevent hypoxemia. Go ahead. We'll talk about this as we go along.
Can I ask a question, please? Can I have a question? I have a question. So are you saying that the tidal volume should be on the low end? So 350 for a 60 kilogram person as opposed to 600?
Okay, so yeah, the lower the tidal volume, the better it is, but you guide with the peak airway pressure. Okay. So if your peak airway pressure is within normal safe range below 30, you can go up on that. That's fine.
Thank you.
Plus, you can also allow for permissive hypercapnia.
We'll talk about that later as well.
Right. So then you have your peak that you monitor. If you or I were going to bed right now with our healthy lungs, our peak airway pressure would be 10 and 15. To give you an idea of that, the stiffness that can happen with the ARDS patient. And then we have your IE ratio. Now your IE ratio is important because that's your time for inhalation and time to exhale. You want to have, for the COPD patients, to have a lot of air trapping. You want to give them time to exhale that out. So higher flows gives them that time.
Okay, another word, the I is inspiration, the E is expiration. So I time means inspiration time is shorter than expiratory time, but that is in case of patients who have COPD or normal patient. Okay, so it is 1 to 3, 1 to 2 is normal, but it changes when the patient have ARDS. So that's the reason we say inverse ratio. So that we'll talk about this briefly later on, okay?
Again, yeah, we talk about it now so we're there.
Okay.
It's okay to have a 1-to-1 ratio or even a 5 time and a quarter E time because the lungs are fast, okay?
It's like an elastic band, you know, see, very, very elastic. Is hard to expand it, and there's a loose elastic, it's easy to expand. So when ARDS is an example of very, very stiff elastic. So if you let it completely collapse, you have to use more force to open up. So it's close and open it up because there's a lot of exudate inside the alveoli when you have ARDS. So we don't want it to completely collapse. We want it to keep it open a little bit so that when we extend, we don't have to use as much pressure and things like that. So that's the reason we change the IE ratio. So it means we give less time for exhalation. So some air stays in, the gas exchange happening still, because not all the O2 is extracted by the alveoli. In the meantime, we give more. So in this way, we don't have complete closure and opening of alveoli, and that creates the lung damage. So we want to prevent that. So that's the reason we change the ratio.
With the PEEP, we can do what's called the best PEEP study, and the PEEP is what stays in lungs when you exhale. And you can put higher PEEP in these patients, and they can tolerate it and improve the oxygenation. If we do when we do the studies, we make sure that we give them the best PEEP possible without overextending the lung, because if you overextend the lung, you have problems with decrease in venous return. You have lung damage. So the best PEEP study actually tells us what the level is for the best PEEP, for the best oxygenation for that patient.
Okay, so PEEP. Describe what does PEEP stand for.
Positive end expiratory pressure.
So it means that PEEP is given after an expiratory. It gives the PEEP. Okay, it's not during inspiration. It's an expiratory pressure. Okay, so keep the alveoli open. Okay.
So when you go through and you got your patient, you do your blood gases on the settings. If your oxygenation, I don't know, a PO2 of 60 or higher, I would be happy with.
Okay, so Oxyhemoglobin dissociation curve, those who were doctors, remember we took the board and all those things. So more or less, it's not exactly. In blood gas, when we get PaO2, means partial pressure of oxygen in the blood, equals almost 90% of saturation. So the correlation is that in the blood, you need 60 and above. It will correlate with O2 saturation, which you check. We can also get in blood gas, the O2 sat, which is actually correct. Pulse oximeter is equal to 90 and above. We can keep the patient's O2 saturation 90 and above. That would be great. If we can, 88 and above. If we can, at least keep around 85 and above. So as low it goes, then you have N organ damage. Means you'll have heart failure, also cardiomyopathy will be one. You get tachycardia, arrhythmias. Then you can get renal failure. You can get ischemia of others. So if N organ failure happens, then God help us all. That is a major problem of ARDS. So if we cannot oxygenate, then we will have a lot of problems. Okay. That's a good question. No, not all these patients have art line. Having an art line is a good thing because you don't have to poke again and again, because once you poke, then there is a arterial spasm and you may not have it. To have an art line, good. The bad thing about heart line is art line doesn't remain stable for more than 1 or 2 days, very rarely. So if you can get the art line in initially, those people have a bad ARDS, that will prevent frequent puncture of the arteries and things like that. So we may try to get it. But I have a bad experience. After 2 days or 3 days, it doesn't function and things like that. So art line is a good thing to have. You can have blood gas done very frequently.
Like the curve you were talking about, the stat, 99 to 90 is good, 88, and then all of a sudden, stats below 88, take a dive. So we won't talk about the shifts and all that. So then you find out, okay, everything we're doing here is not working for this patient because they're just not oxygen. That's when we consider.
Okay, so another reason why patient will be, remember I'm talking about peak airway pressure? So we're giving, PEEP is increasing. For example, here is PEEP is 1. Usually we don't give PEEP. So it went up to 5 because oxygen level is still low. We're giving 100% oxygen, but the oxygen saturation is still low, dangerously low. So we go up on PEEP. We went up to 15. What happened? It will happen that peak airway pressure will keep on going up too, because you're increasing the pressure in the lungs. So then if it becomes 30, 35, 40, now we are in a danger zone. We can develop, a patient can develop pneumothorax. In that case, we may switch to pressure control. So she will explain you what pressure control means. We have to set the peak pressure. Beyond that, the pressure of the lung won't go up, because that's called lung protective strategies. Okay, so she will explain to you.
Basically, with pressure control, you're given a breathing rate and you're given an inspiratory pressure. And when the breath is delivered, it will go right up to the pressure that you want. So say like we want a peak inspiratory pressure of 24. Okay, that peak is the flow given to the patient will peak to 24 and it will hold at 24 for as long as we dial in the inspiratory time to hold it that long.
Even though the tidal volume won't be the one we give. So we can control the tidal volume. We depend upon how is the stiffness of that. Okay, so this is a pressure control. Volume control means volume is given what you put it in. If you put 600, the lung will give 600 most of the time, and no matter what happens. Let's think that way. Okay, there is some pressure relief valve there. If it is too high, it stops. But pressure control, we controlling the pressure. We're not controlling the valve. So maybe the lung becomes so stiff, it's like a sponge full of water. It cannot expand. Then you may get, instead of 600, you get 300 now. Because we are stopping at maybe 35, for example. There's even 35 is the peak we put at. So the problem now occurs. We cannot ventilate. Means carbon dioxide level go up. O2 may remain the same or something like that. Then what happens? pH drops. So pH drops, then we change this into inverse ratio. So we're giving more time to inhale. Those patients become very uncomfortable because you breathe in and then you less time to breathe out. We have to paralyze them, sedate them, so that they were just comatose basically, because the ventilator does all the job. That is an extreme. Like if people who have very severe ARDS with lung injury, capillary leak, alveoli are full of exudate, that becomes inverse ratio, pressure control. Then we tolerate CO2 going up and up 90, may go to up 90. pH is 7. Actually, studies have done in Europe and in New Zealand that can survive with pH less than 7. Keep the oxygenation okay, but we don't want to go to that extreme. I have tolerated up to 7.2, 7.1. In that case, we have to start bicarbonate drip so that at least we can keep the pH close to normal or make it a little high and tolerate high CO2. As you know, these patients who have COVID-19 also develop cardiomyopathy, and we're dealing with viral cardiomyopathy. They may be on pressors, okay, and they may be on fluids. So the other thing is that I advise people of ARDS, do not give albumin, because albumin will leak in the alveoli and you get no problem with oxygen, because I have seen this. Those people have capillary leak syndrome, even the albumin level is low, don't give IV albumin to them. The other choices are try to keep the lung dry lung strategy. But there's a limit to that too. If you dry them too much, because the dry strategy, less volume, less wet the lung is. But if the patient becomes hypotensive, then you're dealing with the same end organ failure. So either the oxygenation is low or the blood supply is low. Yeah, you can give more blood, means you get blood cells to up the oxygenation, but there's a limit to that too. So after 30, you may not get much benefit by giving more red blood cells. So that's clarified.
Yeah. So, you know, during the pressure control, the pressure increasing to that pressure, and they exhale quickly to the peak level. The bigger the difference between the peak inspiratory pressure and the peak level, the more volume they're going to get. The volume will change how the lungs are how stiff the lungs are. If the lungs are stiff, the volume will be less. Okay. Our goal is to try to get volumes adequate to get the CO2s down, the O2s up, and that's your pressure control mode. I think after that, if that fails, then they would consider ECMO.
Yeah. So the problem is that if the ECMO is blood go through the ECMO machine and then oxygenate because lung failed. Similar concept if you think about renal replacement therapy with hemodialysis. When the kidney fails, the machine does the job. But there are not too many ECMO machines available. If the pandemic strikes here and Syracuse is busy, there is no ECMO machine.
So just to reiterate, we do not have an ECMO machine.
We do not have ECMO machine.
And there are only several in Syracuse.
I don't know how many are those. I think there may be one or two.
A couple of Joes and probably but not many.
Not many.
And
I think it's probably going to depend, as we talked about with their ethics committee meeting the other day, depends upon the criteria. I assume it's going to be a regional criteria, but it's probably going to be based upon survivability and potential is for life to be safe.
Okay, so the reason why we transfer, we have to have stable patient. What does stable mean? At least we can oxygenate to an acceptable level. It may not be ideal oxygenation. Their blood pressure is good. They still have a heart rate. They are not in arrhythmia or things like that. They are stable during transportation. They will pass on. So we don't want that. So they have to be stabilized before they can be transferred. If to be transferred, they have to be accepted. So if they have to accept, if they have a place for ECMO for this patient, and if they accept it, then we'll think about transferring either by helicopter or ambulance, depending on what is available. But it all, if we have availability there, if they accept it, either there, Rochester, anywhere. But if the pandemic strikes in upstate, then I have a feeling most of the cities will be in the same situation as we are. The chances are not very good, telling you the truth. Okay, and then we have to take the patient's family in confidence. They won't be able to come and see their family members because we don't allow any patient's family to come because you're going to spread the disease. So this is a difficult situation because family members wants them close to the to the patient when bad things happen or they are close to that, so that they can comfort them. They won't have that luxury either. Go ahead.
So that's the ventilator in a nutshell. This ventilator is capable of doing the assist control mode, which is where you would start, and it's capable of doing the pressure control ventilation. This ventilator is a portable ventilator. It's the LTV. It is also capable of doing the same thing this does. This has a lot more controls that you can play with, the flows and things, and monitoring the machines. But this will also do the job. Okay. This ventilator is also capable of ventilating 2 people at the same time. The people would have to be similar in size. They would have to be paralyzed. There's a lot of factors involved, but if worse actually came down to worse, it's life or death. We're able to ventilate 2 people at the same time. And I found the circuit over here to demonstrate how that would be if you guys want to look at it later. I can show you. But basically, instead of one hose coming
There's a
out
wide. Mhm.
the flow at the machine, we would split it. So now you have here, I'll take that hose here.
Something
You
like this
have one patient
Mhm.
and the other patient.
So you have 2 of them. Yeah.
I would be here with a T, and then the other patient, I would breathe in, and then I would breathe out to a hose here.
But there is a filter, okay? There's a filter around, so that prevents bacteria and viruses going from one to another. Hopefully that filter will prevent,
Yeah.
okay?
Yeah, everybody's got their own
Yeah.
filter. There's no, each person gets their own volume. It's going to be the same volume, but if their lungs are stiffer, if they're not, it's going to be a little bit less.
So it's not going to be a perfect science. This won't tell us exactly. If we can give us total of how much tidal volume we are giving, we don't know how much one is getting and how much the other is getting. So we don't know the peak airway pressure. We may get the combined peak airway pressure. So it's not a perfect science, but at least it's a life-saving strategy.
So Mohammed, you'd have to go up to double the tidal volume.
Yes.
Double
Mhm.
everything.
Exactly.
4 people, quadruple the tidal.
Yes, if we can do 4 people too, but we have to have a bed. In ICU, we can have 2 only. I don't think so we can have more than that. If we can find a place where we can have 4, we can do 4 too, but God help us, I don't know how that will happen, but we have to save life. ARDS is that if you go through that ARDS initial phase, if we can save the life and prevent end organ damage or sepsis, then they usually recover. So that initial part is the toughest part. But if they become very hypoxemic, even with all the modalities we use, and ECMO is the only choice, that may help. Otherwise, there is no way we can save anybody.
They actually successfully did this last night.
The other thing is that we used to have IPPP machine before that you could have been used for ventilator, but we gave that out because it became a very old thing. The other thing is a BiPAP machine, which we have it, and I think it's not a bad idea. God forbid we need more ventilators than we have. We can ask the general population who has a CPAP or BiPAP may donate us. I mean, I know they have sleep apnea and everything. See if they can help, or one of the sleep labs, or even the veterinarians actually can give their ventilators they use for large animals. Now they're using those ventilators for human beings. You can use that too.
I don't know.
Okay, so I just want you to come over here. So the 2 concepts we talked about, because the ventilator management is a little complicated than it seems like. 2 things you have to remember. There's a volume control and the pressure control. Volume control, these 2 modality could be volume control. It's synchronous intermittent mandatory ventilation. It's assist control. It could be volume 2. It could be pressure 2. So you can change any of these mode to either volume control or pressure control. In volume control, we control the tidal volume. We tell the machine to give 500, it has to give 500. Here we tell in pressure control, the peak airway pressure cannot go above, for example, 35. Won't go above 35, but we don't guarantee the volume. Here we don't guarantee the pressure. So it all depends. When the lung becomes stiff, we concentrate on this because we do not want to create pneumothoraces and we don't want to create alveolar damage. So we move to this. Again, IE ratio, I time is less, Then the expiratory time, which is always a little longer in usual cases, but in ARDS, we reverse it. When we reverse it, then it becomes inverse ratio. So either 1:1 or 2:1 or 3:1. I haven't done 3:1, but it can happen too. So that is another thing. Yeah, the people have a COPD, we give the longer time to exhale, but they may change. If they develop ARDS, we may have to change the setting. Any questions or any other thing you think we should talk about? Because it's complicated. There are many other modalities, but these are the common.
So what you're telling us is that the most common thing that we're going to start with, if we're on our own,
We'll
if
start
there's
with-
not a respiratory therapist or a care physician available, it is volume control, assist control.
Yes.
Start there, set their total volume to what? 25 to 50 cc's
To 6 cc per kilogram of the body weight, tidal volume rate. Let's start with 14 to 18, around there, depending upon what the pH shows. Okay, oxygenation 100%.
Yeah.
Okay, and the PEEP of, let's put a number, maybe 5.
But somebody like my size with 100 kilos,
Mhm.
you wouldn't give me 600 cc's. You would probably put me down 500, 550.
Yeah, you could be eligible for 600. You should not do it, but depending upon the peak airway pressure. But we will start lower, 500, maybe 550 or something.
Yeah, thanks.
Could you go over-
Yeah, the new guidelines are lower tidal volume.
Right, I thought
Higher
it was
rate.
more like 4 to 6.
Yes.
You know, so I mean, I would start a little lower in the emergency department and see if I get good oxygenation and good ventilation. Remember that there's different things. Ventilation is getting rid of CO2, oxygenation is oxygenating the patient. And then go up from there, watching our peak pressures, making sure the respiratory, you know, making sure the patient has good sedation with propofol, very important.
Mhm.
If not propofol, then other sedation or sedative paralytics used to make sure the patient's not fighting the ventilator. I think that's another good point to use, right? If the patient fights the ventilator, all bets are off.
The minute ventilation, minute ventilation is a product of frequency, that is the rate, and the tidal volume. So if you can't make up with the tidal volume, we have to give a lower tidal volume or increase the rate. But if you increase the rate too much, then you don't have a chance to exhale at all. So I have gone up to 24, rarely I've been above 24. So if you start low and go up, if your CO2 is high, the oxygenation is okay, you can increase the rate up to 24. Go up to 30 or something, I don't think so you get much benefit because you don't have enough time to exhale. You understand what I'm trying to say? So that is the thing here. Lower volume is good, but not too low. For you, I'm not going to give 300. Because if it's people who get 300, you have to think about the compliance of the tube.
Right.
That's another issue. Okay. So 1 centimeter of water, the compliance is about 2.6 or 2.3 of this tube. So you multiply that with the peak pressure, then you can get the compliance. So you have to add that tidal volume to the patient's tidal volume because you lose tidal volume. This is using pediatrics. I don't do pediatrics, but pediatrics, they have to look at the compliance of the tube because tube get a little bit, stretched out.
Pediatrics, sorry.
It's that dead volume that's in your trach.
Yes,
It's that dead volume
exactly.
that's in your tube.
The other thing is that volume will
That's
increase too, because with longer tube you use, some of the institution have done to prevent exposure or more frequent exposure to have the ventilator outside the room and close the door, but then you have a longer dead space. Then you have to compensate for that space because the dead space ventilation doesn't do anything, oxygenation. So you have to change the whole setting and seeing all those things.
The normal minute ventilation for you and I and everybody is between 5 and 10 liters per minute. So, I mean, when you're adjusting the volume or the rate, you're also looking at your minute ventilation, which is displayed on the corner of the screen here. And the way this guy is set up, his minute ventilation right now is 7. So if I were to do a blood test on this lung right now, it'd be all right. If it was a real person.
So another thing of propofol, who has used propofol, the ER doc, anesthesiologist, pulmonologist, they drop blood pressure. So propofol is very good, it's an anesthetic agent, but then you deal with sometimes, I'm not saying all, if you use a dry lung strategy, you diurese them, then you have a low volume, blood volume, then you put propofol, you become hypotensive. Then you have to use vasopressor. I hate to use vasopressors just like this because it has other problems, arrhythmia and other problems. and peripheral vasoconstriction and all those things. But that is another thing. So sometimes we may have to use, if they drop a lot of pressure, blood pressure, then we have to think about adding fentanyl drip in addition to propofol, add Precedex or paralyze. But you don't paralyze people without sedation and pain management because it's like zombie. You're just seeing things, but you can't say. And that's an awful feeling. So you can move, but you can't say anything. So they have to be anesthetized. So hopefully propofol will work. We give benzodiazepine, either drip. So some of the people need all 3, 4 of them. Some just need one. Some need combinations of those things. So paralyzation is not very benign because when we paralyze somebody, you take the full responsibility. So everybody has to be very watchful. The other thing is that long-term, I have not used paralytic agent for a long time in ICU because the neuropathy which develop people after being on paralytic agent for a long duration because they have actually permanent damage. They become very weak, sensory and motor problems. But if push comes to shove, we have to use it. Okay? Because the patient won't have to fight. If patient fights, then the pressure goes up and all those things. So when you're paralyzed, you're just doing all the job of the lung by the ventilator.
If we have to deliver respiratory therapy medications through the ventilator circuit, we have an adapter that goes right into the circuit that keeps it a closed system, and we're using inhalers.
So we are preventing nebulizers because what we are hearing that nebulizer may contribute to spreading the virus. So we are trying to, it may be that some may need it, but we'll try to avoid as much as we can and use the HFA, through the adapter, as much as we can. The other thing is that they said don't use NSAID, means Motrin, naproxen, Celebrex, meloxicam, any of those things because the outcome is worse. The other thing is that steroid has not been shown to be any beneficial. It may be harmful. Okay, so try to avoid. And even with ARDS, steroid didn't help. There is a theory that at the third recovery part of the ARDS, if you give steroid, it won't be harmful. It may be beneficial, but initial first or two, when there's a severe inflammation going on, it's not very helpful.
I think it would be helpful to all of us just to turn off the ventilator and then turn it back on and just to show us how you quickly set it up.
Okay. When you first come in, this cap will be on the circuit. All right. It'll be here like that. You have to take this cap off before you even consider turning on the vent, or it goes into safe mode and you won't be able to get it out. All right. So
This is connected to the endotracheal tube, am I right?
Yep, this is
This is
the
the
patient.
endotracheal tube, yeah.
Okay, we have the Ballard. What do we put here? And your patient would attach here after they're intubated. All right, so we'll go ahead.
I'm going to be like a patient. Okay, here we are.
Just don't put the pressure on there. There you go. Because when I turn on, to turn on the ventilator, if you come in on the front of the ventilator, there's an on-off switch. You're going to turn it on, and when the screen lights up, you're going to go. I'm going to keep it the same patient. Yeah. You have 3 choices. Check safe, short test mode, new patient, same patient. I'm going to keep the same patient because that's my lung. And then as soon as you click that button over here on this side,
Come over here.
the gray button that you have to push. Oh no, that's for test mode. I'm sorry. Scratch that. Same patient, and you hit press accept if okay. The accept button is over here. Those are the settings. Now it's waiting for the patient to be connected. Okay. As soon as that.
We connect the patient. Okay. Here's
as soon as the patient is connected, the ventilator will start. Okay.
So,
I got an oxygen sensor alarm. It's because I've got it running on the room air right now.
so does it automatically come up under assist control? Does it automatically come up under?
It will default to assist control. Or
Yeah.
whatever.
If that's a different patient, what are you going to do?
Pressure control.
Let's say it's a different patient.
Okay.
So instead of the same patient,
Okay, we're
I
gonna
turn
do.
this on, you pull this ventilator out of the closet.
Okay.
Okay. All right.
Pull
Go
this
in.
ventilator out of the closet, we're gonna start from scratch.
Gonna turn it on. You get your choices, the safety check, new patient, same patient. Now we're gonna go new patient. We're gonna go new patient, click that. Now it wants your ideal body weight. Okay, I'm gonna go 65. You turn the knob to determine your ideal body weight.
Ideal body
Any
weight.
changes, this knob here makes the adjustment. And then you would hit continue. And now you choose your mode. You want assist control. Okay, we'll accept that. Now these are the recommended settings for that patient of 50 kilos. Okay, you can go ahead. We would adjust the flow up a little bit. I would put it on 60, turn the knob. All right, and the tidal volume, what do we have, 300 for the lungs? For a patient, you would go 400 or 500. Type that the tidal volume, that was the apnea setting.
It's 400.
400?
Yeah.
All right.
Okay. And
Flow.
the frequency.
Your rate,
So you press this and then you turn the knob, okay?
accept, 100%, 3 a peep, that's recommended. I like to have the
Okay.
ramp flow.
So this is another thing. Can you go back?
Yeah.
Okay.
You
This
click
is
that.
a rectangular or square, sorry, and then change to decelerating.
Yeah.
So this is the best flow. Okay, we need this ramp. It goes up, down, deceleration.
Basically, what it does is it
Yeah.
mimics your inspiration.
Yeah, decelerating
Instead of a
ramp.
constant flow, you're
This has a best chance for good oxygenation. So remember this.
Okay, turn it, accept. There you go. And hook up to the lungs.
So it actually starts to get breath automatically when it hooks up to
As
the
soon
patient.
as it hooks up to the patient.
These are the two lungs. Okay, so this IE ratio 1:1 is almost inverse ratio. So when you change to 1:3,
I wanted it to go 1 to 3. I would do a faster inspiration.
so you have to go up on this one, yeah.
Yeah, it's right
And go
now.
down on the rate.
Yeah, because we had it. Oh, actually, we had it with 18. Because these are long, it's very difficult to.
Can you increase the peep to 10, see what happens?
If
See
you
how it
increase
looks
the
like the
peak to
lungs.
10, your peak airway pressure is going to be higher. Okay, see how the.
See that? It goes up. Look at the lung. It's not completely collapsing.
Increase the peak.
Yeah, we increase the peep.
Yeah, I see they might be in the ICU. I don't know.
I got to adjust these settings.
Okay. So any other question? This is a start, am I right? So as the lung gets better, we can go, how will you know the patient is getting better? With 100% O2 sat, the peak airway pressure going down, ABG showing 100 and PaO2 much better, saturation is above 100%, and slow going down in FiO2 and P until the patient has a long process to go through that. And then we decide to extubate depending upon what the negative inspiratory pressure is, what's the ABG on trials, and all those things. So assist control is the easiest to use. SIMB is similar to assist control other than synchronous intermittent mandatory ventilation. In what's the difference? So, for example, if you set this mandatory ventilation, machine will give, I'm just giving an example, 12 breaths per minute. That will be the job of the machine. If the patient takes it or do not take it, machine will give it. Synchronized means machine will give that 12 breath in synchrony with the patient's own effort. Negative pressure, -5, -1, -2, will give the mandatory 12. But the patient has to breathe 18 times per minute, and the rest, which is 6 extra breath, patient has to breathe him or herself by taking extra breath. So they have to work.
So we are doing it.
The machine won't give this extra breath. To make it easy, to make the things more complicated, we add pressure support. So when they do the spontaneous breathing, the pressure support decreases the resistance of the tube. So it depends upon, just remember the number. If you have to put the pressure support, put 8. If you're 8, you're fine. You can go up on it depending upon what the tidal volume you're getting. So patient, when it takes, for example, 12 is set, patient's taking 18 breath. 12 is given by the machine. The 6 extra patient has to take. We want patient not to tire out. We want some help at least the patient gets, so they get pressure support when the patient take breath in. So it decreases the resistance of the tube so patient can breathe a little easier. What is the advantage of this? Theoretically, it prevents the atrophy of the muscles of the breathing. But there's a controversy about it, whether it really helps or not, or rather to get TPs, trials, and other things. But that's a whole different subject. Okay, so I would just go for volume control, assist control, start with, and then go to PC, assist control. I think you can manage most of the problems. Do you have any other question? Is it any help? I mean, I know it's just kind of a little, okay.
The respiratory therapist will let you know.
Yeah,
what's
they
going
will
on.
let you know a lot of
They'll
stuff
tell you
because they're more
what pressure's going
experienced.
on, or the oxygenation isn't adequate.
The loss. The real person is a whole lot easier than 1,000 times.
Anybody from video, they want to ask any questions?
Can we ask?
Yeah, no, they're all unmuted. Does anyone have any questions?
Could you show us how you put in pressure support?
For pressure support,
Yeah, to add pressure support.
I do,
To
to add
IMV,
pressure,
change to
you have
IMV.
to go into
Okay, so only
SIMV.
IMV have a pressure support.
Or
Assist
CPAP.
control doesn't need pressure support because every breath, even if a patient, if you set, for example, if you set 12, if patient breathe 18, assist control will give all the 18. If the patient doesn't breathe at all, this patient get 12. So IMV, change to IMV and see if you can.
Yeah,
get the
and
pressure.
basically, pressure support is just to help override the resistance of the endo tube when you're doing the spontaneous breath in between. So to go into get the pressure support, you have to go into vent setup and change the mode.
You want pressure, you want to know about pressure control or pressure support?
Pressure support.
Or pressure
Okay.
support.
All right, so I'll show you how to do the
And
pressure
could we keep
control.
the screen close up?
You would go into the setup, hit the mode that you want to change and bring it down to SIMV, and you would hit accept or continue and then accept, and it switches it to the SIMV mode. And this here, right here, PS is your pressure support, and would never go below a support of 8. Okay, and you adjust the pressure support with the spontaneous tidal volumes
Okay,
of
so-
the patient anywhere from 3 to 700.
Okay, so now listen, you see keep eye on the tidal volume, okay, what they're getting. Okay, so if the tidal volume of the pressure, if the tidal volume is 100, of the spontaneous breathing, you can go up on pressure support until you get 250, 300 at least of the tidal volume. So you can play with, but at least start with 8 and you can go up on it. If you make it too high, then you basically patient is being supported almost 100%.
Yeah,
Okay?
pressure support isn't something that we're going to be using with the ARDS patient. We're using the pressure control.
There's a bi-level too, other type, but I'm not going to go into that because it becomes more complicated. Then it becomes higher PEEP and lower PEEP and pressure support in each one of them. And so let's concentrate on these two major, and most of the cases will be handled that way.
Was this meeting recorded?
Yes.
Okay, can you send out a link? This is Deepa Maka. I can send you my email if you don't have it.
Yep, we can do that.
Thank you.
Well, would it be possible to, there were some initial settings and you made some initial adjustments for, when you're first getting onto the unit, would it be possible to maybe have at least some initial settings number-wise in terms of an initial goal for the patient? Obviously, there'll be adjustments, but to just have those initial settings in hand when you're doing this might be helpful.
Initial setting, just the numbers. I'm just throwing a number. It doesn't, not only 550 plus 5, 100% FiO2 in the range of, let's make it 14. Okay, so let's start with that. Then we can play with it later.
Repeat?
Pardon?
Repeat that?
Okay, so 100% FiO2 plus 5 of PEEP, 14 is the rate, and 500 is the tidal volume.
And this is in volume control.
Yes, exactly. You're right.
And we would check a blood gas within the hour to make sure that those settings are adequate and make any adjustments according to the blood gas. If the PCO2 is high, we would increase the rate and or we increase the tidal volume as long as the peak airway pressures are okay. If we're overventilating, if they're alkalotic, we would turn down the rate.
Let's start with initial this, wait for the ABG, then we'll decide further change. Any other questions?
Do we have to adjust that I to inspiratory expiratory ratio?
The respiratory therapist will adjust that when lung becomes stiff, then we'll discuss about changing the ratio. So the initial will be 1:3 or 1:2 at least, you know, when we start. Okay, I think we are in a good shape.
Thank you, everyone.
Thank you.
Thank you.
Thank you.
So I'm helpful as if I'm alive. Anything can happen. You know?